This video will explain the events that occur during the acute inflammation. The references for this video are following. We know that acute inflammation undergoes sequential steps. First, there is recognition of the injury. Recognition of the injury that in that the phagocyte detect microbes or dead cell. Then there is mediator release. There, cytokines and lipid messengers they trigger inflammation. Then, in vascular response, the blood vessels dilate and become more permeable. Then, the leukocyte recruitment occurs in which WBCs exit circulation and migrate to the injury site. And finally, this is eliminated. This offending agent is eliminated through the process of phagocytosis. So the first step in the inflammatory process is recognition of microbe and damaged cell. So the body has got some specific mechanism for the recognition of the insulting agent. There are some receptors, cellular receptors for the microbes that are present on the plasma membrane, endosome or cytosol. Then there are some sensors of the cellular damage and uric acid, ATP, decrease intracellular calcium concentration and DNA can be sensed specifically by specific cytosolic receptors. Then uh, after this, there is activation of a multi-protein complex that is inflammasome, and this inflammasome is activated and then it produces interleukin 1, and this interleukin 1 is responsible for further recruitment of the leukocyte to this area. Sometimes there is autoinflammatory syndrome in which there is gain of function mutation in the sensors uh, of these inflammasome activation. Same inflammasome activation is also seen in urate crystals, the cause of gout, lipid accumulation, cholesterol crystal formation, and amyloid deposits in the brain. Then there are some other receptors, cellular receptors that directly recognize the microbe, and these are receptors for the Fc tail of antibodies and for complement protein. They opsonize the microbe or invading agent and make them palatable for the body's immune response. Then there are some circulating proteins that are responsible for the recognition of these invading agents. These are complement system, mannose binding lectin, and collectins. These collectins are part of innate immunity, and these are collagen containing C-type lectins. So the mechanism of recognition in this inflammatory process can be summarized as cellular receptors for microbes, and these receptors are TLRs on plasma membrane, endosome or cytosol, and these are found in epithelial cell, dendritic cell, macrophages and leukocytes. Why? Their function in the inflammation is that detect extracellular and intracellular microbes and trigger cytokines and inflammation. Then sensors of cellular damage are site-specific cytosolic receptor that recognize the damaging agent such as uric acid, ATP that is resulted from damaged mitochondria, low intracellular potassium, or cytoplasmic DNA. And they activate inflammasome, and these inflammasome first they secrete interleukin 1, they release interleukin 1, and then leukocyte recruitment is set. Then there is Fc receptor for antibodies and complement protein that are present on leukocytes, and they recognize opsonized microbes and promote phagocytosis, also the inflammation. Then there are some circulating proteins such as complement, mannose binding prolactins and colectins that detect microbe, enhance opsonization, and activate complement mediated inflammation. So there are three major vascular events that are present in acute inflammation. First, there is dilatation of the small vessel that lead to increased blood flow to that particular area. Then with the dilatation and increased flow, there is increased permeability of the microvasculature that allows the plasma protein and WBCs, leukocytes, to come out of the vessel, and these are immigrated from the microcirculation and accumulate at the focus where the injury is going on, and they are activated, and after their activation there is elimination of the offending agent. So blood vessel reacts in acute inflammation, and there are two major changes. There is change in the vascular blood flow, and also the permeability of the vessel is changed. And due to these two changes, there is outward movement of plasma protein and leukocyte toward the site of infection or injury that result in accumulation of the fluid. This accumulation of the fluid can be in the form of exudate or transudate. The exudate is it is an extravascular fluid that has a high protein concentration and contains cellular debris, while transudate or ultrafiltrate of the plasma is a fluid with low protein content, mostly albumin, and it has got little or no cellular material and has got low specific gravity. This transudate is formed due to result of osmotic imbalance between various forces in the capillary network. Then these two terms are very important. Number one is edema, and edema is the excess of fluid that is present in the interstitial tissue or serous cavities, while the pus is a purulent exudate, is an inflammatory exudate that is rich in leukocyte. Predominantly these are neutrophils, the debris of dead cell, and in many cases microbe. So pus is comprised of leukocyte, debris of dead cell, and microbes. So this picture is showing the development mechanism in the development of exudate and transudate. So normally the hydrostatic pressure balances the colloid osmotic blood pressure. There is increased hydrostatic pressure and decreased colloid osmotic pressure that contains the plasma protein within the vascular lumen. But as there is inflammatory process, there is formation of exudate that is due to leakage of these proteins outside from the vascular tissue, vasodilation, and also the leakage of the protein outside. So due to leakage of the protein, the plasma oncotic pressure is decreased, and along with protein, the water also accompany these. So there is accumulation of the proteins, high protein content in the interstitial tissue. As compared to this, there is increased hydrostatic pressure and decreased colloid osmotic pressure. There is no damage to the endothelium, but there is fluid leakage outside toward the interstitial tissue or extracellular space. Okay, so there is decreased colloid osmotic pressure, and it will result in the edema that has got low protein content, no or very few cells. So now, how these changes in vascular flow and caliber are responsible for the cardinal signs of the inflammation. As there is release of histamine and other mediator, they act on vascular smooth muscles and such of the arteriole and capillary bed, and they are result in vasodilation. This in turn is responsible for redness and increased heat in this area. After vasodilation, there is increased vascular permeability and protein-rich fluid in the extracellular tissue extravasate. There is obviously a stagnation of the blood, and the blood flows to that particular area is slowed down. So the concentration of the RBC is increased, and also the blood viscosity as a result is increased. So this is the stasis. Then this stasis results in engorgement of small vessels with slowly moving red cells. After the stasis, the leukocytes, they accumulate along the vascular endothelium, just like pebble stone. They accumulate along the vascular epithelium and responsible for the activation of the endothelial cells. After this, they adhere to the endothelium. The activation, they adhere to the endothelial cell, and finally they migrate through the vascular wall into the interstitial tissue or the site where the inflammatory process going on due to infective or insulting agent. So increased vascular permeability or vascular leakage, especially the permeability of the post capillary venule when increased, it is the hallmark of acute inflammation. Here you can see in this area, here the blood is flowing, there is lamellar flow of the blood, and the plasma proteins are inside, and the endothelium of the blood vessel is intact. So what happens in the uh, acute inflammation? There is retraction of the endothelial cells, like you see here. Here there is contraction of the endothelial cells, and due to contraction of the endothelial cells, there is increased in gaps through which these plasma proteins are leaking out along with the blood cells. So this occur as a result of histamine, bradykinin, leukotriene, and other chemical mediators, and it is termed as immediate transient response because it occurs rapidly after exposure to mediator, and it is usually short-lived. Within 15 to 30 minutes, it vanishes. In some forms, such as burn, irradiation, ultraviolet radiation, exposure to certain bacterial toxins, there is a delayed response. It starts after a delay of 2 to 12 hours and it lasts for several hours or even days. This delayed prolonged leakage may be cause of the contraction of endothelial cells or mild endothelial damage initially. One of the example is late appearing sunburn. Some of the endothelial injuries that are severe, they result in endothelial cell necrosis. As you can see here, the endothelial cells are necrosed. They result in endothelial cell necrosis and they are detached from their basement membrane, as happens in severe injuries, burns, and certain microbes and microbial toxins. Uh, there can be increased transport of the fluid or proteins through the endothelium, that is termed as transcytosis, and it involves intracellular channels usually, and it is stimulated by certain factors such as vascular endothelial growth factor that promotes this vascular leakage. So it is channel mediated and it is through VEGF promoted. Okay, and but this involvement of VEGF in acute inflammation is uncertain. However, the VEGF contribution in chronic inflammation is well established. This picture is summarizing the events we have just discussed. Normally the vessel wall or the normal venule is sealed by tight junction that do not allow any leakage of the fluid outside. There are tight junctions that allow that do not allow any of the fluid or cell to move out of this area. While when there is activity by some vascular mediator such as vasoactive mediator that or some injury, these are retracted. Now these tight junctions have gone and there are gaps in between these endothelial cells through which the cell and content they move outside. This is a short-lived, this is a, as you can see in this graph, this is a short-lived reaction. While when there is severe direct injury to the endothelium, there is formation of bleb and these cells they detach from underlying basement membrane and there are areas of denuded basement membrane. There is no cell above this basement membrane, empty basement membrane without any cells, and they allow prolonged and rapid flow or migration of cells and fluid out of the vascular compartment. And obviously, as there is extensive damage and this damage has taken away the endothelium also, so it is a prolonged response. This covers a long time. So here we can summarize the events that occur during the acute or during the increased vascular permeability. What are the events and their characteristic? In endothelial cell contraction, the triggers are histamine, bradykinin, leukotrienes, and other mediators that increase interendothelial spaces, and due to these increase in the interendothelial spaces, there is leakage of the fluid. This is short term, 15 to 30 minutes. Then there is a delayed prolonged leakage that occurs in burns, ultraviolet radiation, and bacterial toxin. There is mild endothelial damage or delayed contraction of the endothelium. So it starts after 2 to 12 hours and lasts hours to days. Then severe endothelial injury that occurs in burns, microbial toxin, and after the neutrophil adhesion to the endothelium, activated neutrophil. There is direct endothelial necrosis and detachment of endothelium from the basement membrane. It is of immediate onset and it is sustained for hours. And we have also discussed the transcytosis, that is increased transport across the cell, which is facilitated by the VEGF, vascular endothelial growth factor, and other mediators through which the protein and fluid moves out and it contributes to the permeability. But in acute inflammation, its role is uncertain. However, it is well established in chronic inflammation. As the blood vessels are affected, the lymphatic vessels and lymph nodes are also affected. The lymphatic vessels polisses the fluid that is coming, some extra fluid that is draining out of the vessels, capillaries to the tissue. It goes through the lymphatics towards the circulation again. So if by any means there is increased leakage of the fluid, increased leakage of the proteins, with the proteins and with the fluid, some microbes or damaging agent can also come into the lymphatics from the interstitial tissue, and that will result in secondary inflammation of the lymphatic channel or lymph node. So here these are yellow streaks. These are evident and these are the result of lymphangitis, the lymphatic channels inflammation. Also, some of these microbes can gain access to the draining lymph node. Obviously these channels, they drain to regional lymph node, so the microbe can get access to regional lymph node and the lymph node can be enlarged. So the enlargement of the lymphatic gland is termed as lymphadenitis. And here this microscopic picture is showing that there is a reactive or inflammatory changes that are present in this lymph node with formation of active germinal centers. As there is vascular leakage, damage to the endothelium, there is development of more lymphatic fluid. So there is increased lymph flow, and this lymph flow increased and it drains excessive edema fluid, leukocyte, debris, and other microbes. So this is a very important mechanism for clearing away the exudate that is formed. Then the lymphatic vessels also proliferate. This proliferation increases the draining capacity and it supports immune response, but it may spread the infection to other side. Then there is lymphangitis, that is second inflammation of the lymphatic vessels, and we have seen the picture that it is present as red streaks on the skin. Then there can be development of inflammation of the lymphatic gland, that is termed as lymphadenitis, and they present due to hyperplasia of the lymphoid follicle, as there is more draining fluid along with leukocytes, microbes and debris is coming toward this lymph node. It has to be cleared away. So the cells lining these lymph node sinusoids, they are hyperplastic, and there is also activation of the lymphoid follicle. As a result, the lymph nodes are enlarged and painful, so can also be termed as reactive lymphadenitis. So there can be increased lymphocytes and macrophage activity, and this is common in infection and immune responses. So in leukocyte recruitment to the site of inflammation, first there are changes in the blood flow and vascular permeability that result in vasodilation and increased permeability, and the endothelial cells and neutrophils were involved, and they enhance the migration of the leukocyte, and along with the migration of leukocyte there is chance of edema development. Then leukocyte infiltrate and they accompany macrophages now with them, and they go to the inflamed area and essential for the pathogen clearance and debris removal. After that, the lymphocyte the leukocyte ingest and destroy bacteria, necrotic tissue, and foreign substance. The major key player are neutrophil and macrophages still, and this eliminates the infection, but there is accompanying tissue damage. Then there is production of growth factor, and these growth factors promote repair of the tissue. Here the neutrophils work has done. Now macrophage join fibroblast to start the healing process. Uh, in the inflammation-induced tissue damage, there is involvement of neutrophil and macrophage. If this healing is not done, there is continuous prolonged inflammation as occur in chronic disease. So now the leukocytes are recruited at the site of the inflammation. The major cells that are involved in this process are neutrophils and macrophages. They are also termed as phagocyte or eating cells, and they clear away bacteria and other microbes. They can clear away necrotic tissue or foreign substance, and it is done through a series of cellular events that occur during acute inflammation. These are mediated and controlled by adhesion molecules and cytokines that are termed as chemokines. So, the cellular events that occur during the inflammation, acute inflammation, are divided into three. Some cellular events that occur within the lumen, that are margination, rolling, and adhesion to the endothelium. Then migration across the endothelium and vessel wall. Then migration within the tissue toward the stimulus that is inviting these cells to clear away the damaging or pathogenic agent. So there are three steps. First is the margination, rolling and adhesion. in which the leukocyte slows down and adhere to the endothelium, and it is mediated by adhesion molecules such as selectin, integrin, and chemokines, and it prepares leukocyte for migration out of the blood vessel. First, it adheres, marginate, roll over, and then adheres to the endothelium. Now it is prepared for the migration across the endothelium. And the second step is mediated by integrin and chemokine, and the process involved is diabetesis. And these allow the WBCs or leukocytes to enter the site of the inflammation. Finally, they migrate in the tissue toward the site of the infection or injury, and this process is guided by chemotactic factor, cytokines, or bacterial products. Both can work as chemotactic factors, and they direct these leukocytes to the site where they are needed. So the leukocyte accumulation at the site of inflammation is an essential feature of the acute inflammation. Especially the polymorphonuclear neutrophils are accumulated at this site, and whenever there there is an activated cell, whenever there is an activated cell, it will result in release of some eicosanoid or some leukotrienes, and these interact with neutrophil receptors, serum proteins, and chemokines. Finally, what happens that they recruit more cells from the bone marrow, and the aggregates of these cells, these leukocytes, they release specific cytokines. These are pro-inflammatory, and then they act on the tissue. Some of these are influenced by bacterial endotoxins and viral proteins also. They act on the target tissue, and whenever they act there, they liberate chemokines, and these chemokines then are responsible for further leukocyte that are responsible for the amplification of the acute inflammatory response. The leukocytes that are circulating within the blood, they marginate in this chart of the inflammation, then they roll, and then there is activation of these polymorphs. After this, these cells are adhered to the vascular wall, and after the action, due to action of many uh, enzymes and adhesion molecules, they transmigrate through the vessel wall, and at the site of the injury there is phagocytosis, degranulation of these cells, and production of the oxygen radicals. So what happens from the recruitment till the phagocyte start of the phagocytosis? First, there is endothelial cell activation, and after the activation of the endothelial cell, that is by the pro-inflammatory cytokines, bacterial endotoxin, or viral protein, there is increased permeability of the vessel wall for the leukocyte. Then they adhere to the activated endothelium, and eicosanoid complement and chemokines are responsible for this adhesion with the vessel wall. Then they transmigrate through the vessel wall by the action of integrins and chemokines and some enzymes that degrade the basement membrane, and within the tissue they are directed toward the site of the inflammation by chemoattractants that can be chemokines or lipid mediators. So the leukocytes are directed toward the site of the infection. Finally, phagocytosis starts at the site where the neutrophil they ingest microbes and debris. This is achieved by opsonin complement system and phagocytic receptors, and hence they clear the infection and necrotic tissue. Memorize this picture from Robbins to understand the process of acute inflammation. That is a multi-step process where the leukocytes first they are going in the lamellar flow within the vessel wall. They first move away from the lamellar flow toward the margin. They first marginate a rollover, that is a weak affinity state. Then they bind or adhere with the endothelium and activated. They go through the diabeteses into the tissue, traverse the cell and the basement membrane, and move in a directed way towards the chemotactic stimulus through various cytokines. And each of this step is regulated or influenced by a certain molecule or structure. Each of these steps we are going to study in detail. So in inflammation, there is altered hemodynamic state. So there is stasis. As a result of stasis, the neutrophils are redistributed, and they now are present along the surface of the endothelium, and this condition is termed as margination. Here they lie and they wait for more of the neutrophils to join them, and the neutrophils say that we हमने अक्सर अब तुम्हारी राहों में रुककर अपना इंतजार किया. After that, the process of rolling and then the adherence occur. Now the process of rolling. E-selectin are the one of the molecule. These are one of the molecules that are responsible for rolling mechanism. Whenever there is infection or injury, there is release of certain cytokines by the neutrophil and also by the surrounding or other cells. TNF, interleukin 1 and chemokines are generated by tissue macrophages, mast cells and endothelial cells. Then, especially the endothelial cells of post-capillary venules, they are affected or they are prepared by TNF, tumor necrotic factor, and interleukin 1 within 1 to 2 hours, and on the endothelial surface, E-selectin and ligand for L-selectins, leukocyte selectins, are expressed. By the action of histamine and thrombin, the Weber-Palade bodies also are responsible for redistribution of P-selectin, and as a result, there is expression of these selectins, and the leukocyte also express L-selectin and ligand for E and P-selectin that are already expressed over here on the endothelial surface. These are low affinity interaction, and uh, they can detach with a faster flow. So the bound leukocyte can detach with the faster flow, and they can then bind again. And so the process of rolling starts along the endothelial surface. Before going into the further details of cellular events of acute inflammation, first I would like to go into the details of the adhesion molecules that are available. The adhesion molecules are selectin, adenosine, integrins, and immunoglobulins. The selectins are expressed on platelets, endothelial cells, or leukocytes. Hence, they are termed as P, E, and L selectins. They are expressed on these cells. Then these P selectins, they are present within the available pellet bodies of the platelets, and whenever on the of the endothelium, and whenever there is a stimulus, they are released from the endothelium and they are expressed on the surface. The E-selectin binds with the neutrophil, monocyte, and lymphocyte, while Lewis 10A, while L-selectins are homing receptors for lymphocyte, binds with glycam-1, metcam-1, and CD34. The addressings that tell the address to the leukocyte, they are glycam-1, PSGL1, ESL1, and CD34, and they are located on the leukocyte and endothelium. And actually, they are mucin-like glycoprotein that bind with selectin for leukocyte travel. We have studied the process of rolling. The integrins are the molecule that mediate the firm adhesion after the rolling part of the cellular event. The integrins are VLA4, LFA1, and CD11A, MAC1, CD11B. They are expressed on leukocytes, and VLA4, it binds with VCAM on endothelial cell and aid in firm adhesion, while LFA and CD11A, it binds with IKIM1 for the firm adhesion, while MAC1 binds with IKIM1 and 2 both to aid in firm adhesion. Immunoglobulin also play their part, and they interact with integrin for the firm adhesion and transmigration. ICAM1, ICAM2 are ICAM1, ICAM2, and VCAM1 are the immunoglobulins that are expressed on endothelium and leukocyte, and they bind integrin to mediate the leukocyte recruitment. While GEM A, B, and C, they are expressed on endothelial cell leukocytes and also on the platelets, and they also aid in leukocyte and the integrin interaction. This is the table from Robbins, and it is emphasizing on all of these molecules that are playing their part in the inflammatory process, that are selectin, integrin, and immunoglobulin. They are expressed on selected cell and have got specific ligand for the interaction that further helps in the propagation or in the firm adhesion of the leukocyte that leads to the or that aids in the transmigration of the leukocyte through the vessel wall. So this picture is showing the process of addition, firm addition of the leukocyte. There is this leukocyte that is present within the lumen. This is within the vascular lumen. There is a still expression of the integrin that is in the normal expression of integrin, and the normal expression of the glycoproteins is the Lewis glycoprotein that is there. When it is marginated, the rolling start. It is marginated by the action of TNF and interleukin 1 that induces the expression of the p-selectin and e-selectin on the endothelial surface. And with this expression, there is application of the brake on these cells. These cells now rolling and they a brake is applied to them by the action of chemokines that adhere or that interact with the proteoglycans that are present on the endothelial cells, and through this these leukocytes are attached with the endothelial cells. Then ICAM and VCAM, the intercellular adhesion molecule and vascular cell adhesion molecules, are expressed through the action of the cytokines, and the ligand for beta-2 integrin LFA1 and MAC1 is ICAM, while the VCAM is ligand for beta-1 integrin and VLA4 is here. So what happens next? There is activation of these heterodimeric proteins that are integrin, and due to this, these are now firmly adhered to the surface of the endothelial cell. Finally, they stop rolling. Their cytoskeleton is reorganized, and the leukocyte is spread out on the endothelial surface to transmigrate through the vessel wall through the process of diapedesis. So normally in the physiological state, there is balance between the pro and anti-adhesive forces in the vascular endothelial cells. There is regulation of these peroxisome proliferator activated receptors, and the physiological stress that is under control reduces the oxygen, the oxidative stress is less, and also the inhibitory kappa B alpha is increased. So there is decrease in signal transduction pathway of the nuclear factor B, nuclear factor kappa B, and then there is JNK-AP pathway that is also decreased. While in the anti, uh, when there are more adhesive forces present, that is in the pro-inflammatory state, there is turbulence of the blood flow, and pro-inflammatory cytokines, lipoprotein, vasoactive peptide, and there are many products that are the result of smoking. They increase the oxygen radicals, and oxidative stress on the cell is increased. As a result, there is increase in nuclear factor kappa B activity and JNK AP that favors the adhesive forces. So all these subcellular events, they lead to pro-adhesive forces dominance. This picture is summarizing the cellular events that occur during acute inflammation. Initially, there is the activation of endothelial cells, and this, along with the teeth ring, that is the expression of E-selectin and other uh, integrin on the surface of the leukocyte. It is influenced by the TNF, interleukin-1, platelet activating factor, histamine, and thrombin. While the molecules that are expressed on the endothelial cells are E-selectin and P-selectins. Then there is a step of rolling, that is saltatory or leaping movement of the leukocyte along the surface of the endothelium, and this is by the selectin PSGL1 and alpha 4 beta 1 integrin, and there is presence of E-selectin and P-selectin on the surface of the endothelium. Then there is involvement of the chemokines that are bind with the glycoproteins that are expressed on the endothelial surface, and then there is achievement of the firm adhesion by means of alpha B4 beta 1 and alpha beta 2 integrins, and the endothelial cells, they have got ICAM and VCAM for these molecules. And finally, when firm adhesion is achieved, the cells are transmigrated through the diapetesis, and the molecules that are involved are beta 1 integrin, alpha beta 2 integrin, denim CD95, and PCAM, the platelet endothelial cell adhesion molecule. On the endothelial surface, there are ICAM, VCAM, CD99, PCAM, GEM A, B, and C. And these steps are influenced by the chemokine gradients that are more effective, and they are responsible for the recruitment of these leukocytes. So there is recruitment of specific subsets of leukocytes to areas of inflammation that result from unique pattern or relative densities of adhesion molecules on the cell surface. The neutrophil express ligand for E-selectin, ESL1, and PSL1, that is the ligand for P-selectin, on their surface, and they interact with P and E-selectin on the endothelial surface respectively, while beta 2 integrin uh, interacts with ICAM1, and the beta 1 integrin interacts with the VCAM. The glycine bearing cell adhesion molecule is expressed on the endothelial surface that binds with the selectin that is expressed on the leukocyte surface. Next step is the migration of the leukocyte through the endothelium, and that is termed as transmigration or diapetesis. Here, after the interaction of the ICAM, VCAM, and alpha and beta integrins, there is presence of PCAM or platelet endothelial cell adhesion molecule on the intercellular spaces. So, with the interaction of these PCAM, that is also termed as CD31, the leukocyte, they traverse through the endothelial cell, and under the endothelial cells there is present of basement membrane, so they secrete collagenases that degrade the basement membrane, and finally they traverse through the interstitial space toward the chemotactic gradient or high chemotactic gradient, or towards the chemotactic focus. So there is presence of PKM, platelet endothelial cell adhesion molecule, junctional adhesion molecule, and CD99 on the surface of these endothelium. Whenever any of these activated or firmly adhered leukocyte arrives, the JAMs or junctional adhesion molecule, they polymerize, and then along with PCAM they facilitate the transmigration process. So this transmigration is actually the migration through the interendothelial space that is achieved by platelet endothelial cell activation adhesion molecule or CD31, and they facilitate the passage of leukocyte through the endothelial junction, and this occurs with the help of chemokines toward the chemical signal, and these signals guide the leukocyte toward the site of injury or infection. There is secretion of collagenases by these leukocyte, and this help to pass into extravascular tissue. Now the leukocytes in extravascular tissue, and they traverse through this extracellular tissue with the help of chemotactic gradient, and they reach toward the site of the inflammation, at the site of the inflammation. So this movement is or the presence of these adhesion molecule is very much important, because if there is deficiency of any of these adhesion molecule, there is defective adhesion, and it will result in recurrent bacterial infection due to defective recruitment of the leukocytes. So the ruling is a process that is majorly influenced by the selectin. L-selectin, E-selectin, and P-selectins are the major molecules that are involved, and there is weak interaction among the endothelial cells and leukocyte, and these roll over the surface of the endothelium. Then the firm adherence is achieved through integrins and ligands, and these ligands and integrin activity with the ICAM and VCAM on the endothelial surface, they strengthen the adhesion, and after that there is transmigration that is achieved by PCAM, JAM, and CD99, and through these molecules facilitate the leukocyte to move through the vessel wall to the site of the chemotaxis. So now the cell that is in the the leukocyte that is inside this interstitial space, it is moving toward the chemotactic stimulus, and this is the process of chemotaxis. So chemotaxis is defined as movement of the leukocyte toward the site of injury, and this locomotion is along chemical gradients. Various chemoattractants are responsible for this. So there can be endogenous agents or exogenous agents. Some bacterial products, especially the peptides with N-formyl methionine terminal amino acids and lipids, are the exogenous agents that are chemoattractant, while endogenous cytokines such as interleukin 8, the factors from the complement system, especially C5a and arachidonic acid metabolite, particularly the leukotriene B4, are the chemoattracting factor. They bind with G protein coupled receptors and activate second messenger system. And there is GTPases activation of the RAC, Rho, and CDC42 family with kinases. As a result, there is polymerization of the actin. This polymerized actin is present at the leading edge of the cell, while the myosin is localized at the back of this area. So this result in filopodia formation. As a result, the leukocyte moves along the leukocyte move in the intracellular space along the chemotactic gradient, and these filopodia work like a front wheel driven car, and after these filopodia, the rest of the cell part, it moves also toward the chemotactic stimulus. So the first step after the transmigration is the leukocyte positioning. First, the leukocytes are positioned uh, by a guided movement of the leukocyte toward this site of the injury, and this is achieved by chemoattractants and adhesion molecule, and this process ensured the timely arrival of the leukocyte at the site of the injury. Then this chemotaxis direct the cell migration in response to the gradient. There is high concentration of the chemotactic stimulants at the site of the injury, and some of these chemotactic attractant or chemokines, they bind to the endothelium, and they uh, guide the leukocyte from the blood vessels to that particular area. Then signal integration from the neutrophilic migration is occurred by C5a formilated methionine peptide, leukotriene B4, and extracellular matrix degradation products and some chemokines. They direct leukocyte along the chemotactic gradient to the injury site. Then there is persistent chemokine concentration at the site of the injury, and these chemokines are bound to extracellular matrix proteoglycans that enhance the leukocyte recruitment and movement. The recruitment of different types of the leukocyte is achieved by various molecules such as platelet activating factor, transforming growth factor beta, neutrophilic cationic protein, and lymphokine that attracts lymphocyte, basophil, and other types of the inflammatory cell. Then finally, when the the leukocytes have reached at the site, the target site, they are held here or arrested here by the contact guidance and inhibitory signals, and now this process ensures the cellular events that occur in this area to correct the tissue damage. So the early cell that appear in this environment, this inflammatory environment, is neutrophil. It appears within early 6 to 24 hours at the site of the injury. This picture is showing the myocardial infarction, and here in early phase there is presence of numerous neutrophil at the site of this myocardial infarction, early injury, and within 1 to 2 days these are replaced by mononuclear cells or monocytes. Here there is abundance of monocytes now, and lymphocytes are decreased. There are reasons for early arrival of neutrophils to the site because they are present in abundance in the tissue, and also uh, they have got rapid response for the action of the chemokines, and they may attach firmly with the adhesion molecules that are the P and E selectins, and within the tissue when they arrive there, they are they undergo apoptosis and they disappear, while the monocytes that appear after 1 to 2 days, they have got the tendency to invade and proliferate within the tissue. So after 2 days, there is predominance of the monocyte in the tissue. as is seen in this picture. There are some exceptions to this. In Pseudomonas bacterial infection, there is continuous recruitment of the leukocyte to this area. In hypersensitivity reaction, there is early involvement of lymphocytes. Viral infection also involves lymphocyte, and eosinophils predominate the allergic reaction. Here, this graph is showing that there is early edema, the vascular changes that occur in early time, and within 2 days, the neutrophil gain maximum number and then decline, while the monocyte that start appearing maximum after 2 days, 1 to 2 days, they have tendency to proliferate, and they also make populations at the site of the injury and are responsible for degradation of the injurious agent. So now these neutrophils are lying in this environment at the site of the injury, and here now they recognize the offending agent, they recognize these through toll-like receptor and other receptor, and there is activation of the leukocytes to phagocyte and destroy these agents that we are going to study in the next video. Now we will study some clinical examples of the acute inflammation. A 22-year-old male presents with periumbilical pain migrating to the right lower quadrant accompanied by nausea and fever. So this is by the obstruction of the appendiceal lumen that lead to bacterial overgrowth, and hence there is acute inflammation. Condition is termed as acute appendicitis. The inflammation, acute inflammation of the appendix. There is edema and neutrophilic infiltration in this condition. A 65-year-old female with sudden onset of fever, productive cough with purulent sputum and pleuritic chest pain, and this is caused by inhaled pathogen that reach to the alveoli and cause acute inflammatory response. There is exudation of fibrin-rich fluid and infiltration by the neutrophil as evident by this picture. There is dense exudate that is present, and there is debris, inflammatory debris with heavy content of the neutrophil that is infiltrated or reached to this site. The condition is termed as acute pneumonia. A 40 years old diabetic woman develops erythema, increased temperature and swelling of the left lower leg following by a minor skin abrasion, and this pathologic basis for this condition is skin breach that allow entry of the bacteria, and there is diffuse acute inflammation of the dermis and subcutaneous tissue, and the condition is termed as cellulitis. This whole area is affected by inflammation. There is redness of this area with increased temperature, and this is the inflammation of skin and subcutaneous tissue, dermis and subcutaneous tissue, cellulitis. A 55-year-old male experienced sudden severe pain and swelling in the first metatarsophalangeal joint, the classical appearance of the gout. Here you can see this reddish area that has got increased temperature, severe pain. This gout is also termed as podagra. Acute gouty arthritis is the condition, and this is due to deposition of monosodium urate crystals that are recognized by the uh, body's system, and there is activation of the inflammasome that lead to the acute inflammatory process. Right upper quadrant pain with fever and vomiting in a 47-year-old female is acute cholecystitis, the acute inflammation of the gallbladder, and it is usually commonly due to gallstone obstruction of the cystic duct that lead to stasis of the bile, and there is secondary infection of this area that cause acute inflammation of the wall of the gallbladder. Urinary tract infection. The urinary tract infection is one of the commonest infection of young women or women of the reproductive age, present with fever, flank pain, and dysuria. And there is the complication of UTI that is acute pyelonephritis. That is ascending bacterial infection from the lower urinary tract to the acute inflammation of the renal parenchyma and pelvis. So here you can see some areas that are reddish, microabscess formation, and these abscesses are present within the collecting ducts. Also, the medullary pyramids are hyperemic. A 28 years old male present with sharp pleuritic chest pain that is relieved by sitting forward, and this is accompanied by fever, and the condition is acute pericarditis, the acute inflammation of the pericardium that is usually result of viral infection that causes inflammation of the pericardial sacs and lead to fibrinous exudate and chest pain. So here there is presence of exudate, and wall is the outer surface of this hard tissue is reddish. Thank you for watching this video. If you have any question, please write your question in the comments below. Thank you.